Dear colleagues, dear friends, herewith I would like to introduce to you our recent algorithm on the optimal state-of-the-art treatment of femoropopliteal lesions, recently published in JACC Cardiovascular Interventions. I will share my slides for you. So, as you all may know, we have nowadays various options for the lesion preparation before the definitive treatment of a peripheral artery lesion, especially in the femoropopliteal lesion. We share the options of atherectomy, lithotripsy, and specialty balloons, balloon angioplasty for lesion preparation, but also drug-eluting stents for the treatment of such lesions. Of course, this is a luxury that we have so many options. On the other hand, we thought together with other colleagues from different disciplines like vascular surgery, vascular medicine, cardiology, and interventional radiology that a little bit more structure may be needed in order to put a central line how to optimally use these tools. This is why we generated this algorithm based on a Delphi consensus and involving, as already mentioned, colleagues from several disciplines. Of course, we took a look on patient characteristics, and we differentiated between the treatment of patients with lifestyle-limiting claudication versus CLTI. Important was also the anatomy, the localization of the lesions. Then in terms of lesion-specific characteristics, the lesion calcification and the ability to cross intraluminally or subintimally the lesion. And then we differentiated between the several lesion preparation tools mentioned previously and on the definitive treatment tools. Among the lesion preparation tools, you can appreciate that there was very good agreement for the use of atherectomy, especially in calcified lesions that can be passed intraluminally, and also in lesions with organized thrombus for mechanical thrombectomy. There was also good agreement for intravascular lithotripsy, less agreement for POBA and for specialty balloons. Regarding the definitive lesion treatment, there was very strong agreement for the drug-coated balloon and also good agreement in case of bailout stenting for the drug-eluting stent. We believe that now with the two algorithms, the one published a couple of years ago in JACC for the optimal crossing of the lesion together with a treatment algorithm published a couple of weeks or months ago this year, that we have an optimal basis for the optimal treatment of chronic femoropopliteal lesions. I would like to summarize that the endovascular treatment is the most common first-line option for the treatment of peripheral artery disease. Endovascular therapy includes lesion preparation and definitive treatment tools. Vessel preparation can improve the technical success rate, but of course, studies and real-world registries on limp outcomes like patency rates and reinterventions are still warranted. If stenting becomes necessary, then prefer spot stenting and avoid long stenting, and if possible, use the drug-eluting stent technology as the preferred strategy. I would like finally to invite you to read our paper recently published in JACC, and thank you for your attention. Bye-bye.